let's get started, shall we? Um, Before we get into this, I just wanted to show you what I have scheduled for the next little bit here. So first, obviously, we have our last regular class, which is on Thursday. I'll be finishing topic 14 and talking about the exam in more detail. So there's that. I have some review sessions planned. And so I have one planned on Friday and one planned on Monday. The one on Friday is in person only, and the one on Monday is Zoom only. And the way it's going to work, they're going to be pretty similar. So you don't need to attend both. You don't need to attend any if you don't want to. It's all optional. If you want to show up and just hang out in the back and maybe we'll absorb something, that's fine too. But they're going to be pretty similar. And the way they're going to run is I'm basically going to go through some of the study questions. Usually I have a handful that I think are good ones to kind of start, and then after that I usually open up and say, to the class, are there any other study questions that you want us to cover? And that's kind of usually how I end up running the review sessions. Maybe throw in a few study tips, things like that. And that's generally how it works. So that's what I have planned for Friday and Monday. Like I said, in person only, Zoom only. And then next week, I have two other sessions booked, and I'm not going to call them review sessions. I'm going to call them study hall. I haven't quite decided how I want to do that. It's going to be even less formal, a little bit more of come in and we can talk about things, maybe cover other study questions. Just wanted to make some more time available for anyone who wants to drop in and discuss things. I also figured by Tuesday, maybe you've done some more studying and people have more questions. Like I said, they're going to be a little less formal in terms of, you could call it a study hall or a group office hour or something like that. And, if people don't have anything they want to look at, then I'll just pick on more study questions and kind of go through them. And then I have an office hour as well. I'll keep it at the same time, 10:30. I'll make sure I'm available and on campus the day before the exam from 10:30 to noon in our regular time. And so Friday is the actual exam. It's in the old gym. Does anyone actually know where that is? Yeah, so good luck finding it. It's kind of hidden and out of the way. I actually only went there for the first time in September. I've been here for more than 10 years. It was the old gym before the Sports and Wellness Center was open, and it was storage up until like last year. They renovated it, I guess, and they're actually using it for training some of the sports teams and a few other events. What I'm going to do, I'll make you a map. If you know where IT services is, it's basically way down there. You pass the library, you go down in the hall, you turn right, you go down the end of that hall, and it's kind of hidden around a corner at the very end. But I'll make a map, and I'll make sure I post that on Moodle at some point. But I would recommend, just a word of advice, always figure out where your exams are before you have to go there. I made the mistake as a student, right? I was supposed to go to room 105 in a building, which I thought was McKinnon 105, and I get there and it's like 103, 104, 106. And I'm like, what? Right? I spent 15 minutes looking for room 105. I found like a broom closet that might have been 105. I don't know. And then this is old school stuff. They never had the exam schedule posted online when I was a student. They certainly could have. There was an internet. I'm not that old. But I had to run over to the library because it was posted on the library window, check it, and it turns out it was not McKinnon 105, it was McLaughlin 105, right? Wrong building. So big mistake on my end. So that's where we're at. Make sure you know where the old gym is. Like I said, I'll make a map for you guys and show it to you on Thursday. So this is where we left off. We had started topic 14. And as I said, topic 14 is a little bit review, a little bit new, kind of putting things in a different context. The context is, of course, infections of the body and looking at the different body systems. So we had started on infections of the skin. I'm just going to move that little thing out of the way. Take that. There we go. Exit off, it stops the PowerPoint, unfortunately. So we talked about the body surface, and we had basically talked about Staphylococcus. So here were some of the ones I wanted to talk about. I wasn't going to talk too much about Propionibacterium, other than it causes acne. But the one I did want to talk about a little bit is Pseudomonas. Pseudomonas, I dropped the name a few times over the semester and said we're going to come back and get to it. It's kind of an interesting organism for a lot of reasons. And special place in my heart, I think I mentioned I had worked on Pseudomonas. And it's very interesting from a lot of, if you're interested in genomes and things like that, it's a very fascinating organism. So it's a gram-negative, which means it's related to E. coli. Excuse me. It can create biofilms, and it's one of these organisms that is really well adapted to living in a lot of places. It can actually be a plant pathogen. It can live in the soil. It can live on the human body. It's very good at living in a lot of places. Usually it's not a threat to people who are healthy, but it is really, really opportunistic, meaning if it gets an opportunity, gets a chance to make a foothold, it can affect multiple body systems. You can see this number here. This is from a couple of studies. Usually it's more on the 10% of nosocomial infections, but some places it's much, much higher. Some hospitals we're looking at, it's even outcompeting Staphylococcus as the #1 hospital-acquired infection. So it's a big deal, and you may notice that other note that it's naturally resistant to a lot of treatments. It is. That's the way it is. It's just very good at doing so. So I'll touch on that in a moment. So like I said, opportunistic pathogen. One thing that's about it that's kind of interesting is when you grow it on a petri dish, it often grows in kind of a greenish color. And I actually had one strain that grew in a purplish color. So that was exciting, right? Everyone loves interesting colors. It has a little pigment it grows, and grows a carbohydrate called alginate, which allows it to grow in a biofilm. So you can picture you've got these sticky mass of cells with all these sticky carbohydrates, and so that protects it from a lot of treatments and makes this green color. So some infections, as a consequence, will often have a greenish color. So there's somebody with some sort of fingernail infection. The next one's a little bit harder to view, but here's a burn victim. And this is one of the organisms that burns victims. It's very dangerous for them to get. You can see this guy here is a burn victim, and you can see the bandages are getting green from the Pseudomonas. And how do you treat that, right? The person already has damaged skin. You can't remove it by surgery. It's hard to permeate the biofilms with antibiotics. It can be very, very difficult to treat. There's a whole range of infections that Pseudomonas can cause. Picture a body system, Pseudomonas probably can infect it. Here's kind of some of the examples of pretty common infections. One of the infections that is super bad is if you have cystic fibrosis. So cystic fibrosis is a genetic disorder, and people with cystic fibrosis, they have secretion issues, and it has something to do with chloride secretion, so they have digestive problems. And one of the things is that they will often have thick mucus in their lungs, and it turns out that Pseudomonas aeruginosa likes to live there. And this is often a death sentence for these people. The lifespan, I don't know what it is. I think it's early 30s. And usually this is what kills them, is they get a Pseudomonas infection in the lungs, and that's kind of that's the thing that ends up getting them, because they can't treat it other than maybe a lung transplant. But all the other normal infections that you're going to see in hospitals that are hospital-acquired infections, so catheter infections, some gastrointestinal infections. So you can see kind of this theme. Like I said, if you're healthy, probably not an issue, but as soon as something is going on, you have a weakened immune system or something like that, Pseudomonas is very good at causing that infection. Some skin infections, like I said, wounds and burns and those kind of things. Ear infections, eye infections. I know somebody who actually had an eye infection with Pseudomonas aeruginosa, and it was drug resistant. So it was hard to treat, unfortunately. So this whole thing about being naturally resistant to antibiotics, if you go back to that lecture on how they resist antibiotics, Pseudomonas has all sorts of enzymes and efflux pumps and those kind of things. And when I used to do research on Pseudomonas, I remember reading a bunch of these papers, and the authors don't hold back. You can see this one here, Pseudomonas aeruginosa, phenomenon of bacterial resistance. This person's just amazed by what they saw. Multiple mechanisms of antimicrobial resistance to Pseudomonas aeruginosa, our worst nightmare. Usually scientists aren't so, when they're writing, aren't usually so colorful in their titles. Multi-drug resistant Pseudomonas aeruginosa towards a therapeutic dead end. Very, very encouraging stuff. So this is something that a lot of people are thinking about because it is affecting weak and vulnerable immunocompromised people. All right, so moving on, you're going to see Pseudomonas probably on some of the other lists when we're talking about other body systems. Like I said, you're going to see lists with these body systems, and you're going to see a lot of the same pathogens that are infecting multiple body systems. Staphylococcus, Pseudomonas, Streptococcus, E. coli, and a couple of others seem to come up again and again. Just want to touch a little bit on some other bacterial skin infections. There are many, by the way. There are many, many bacterial skin infections out there. And sometimes it just depends on the context. There's different bacterial infections if you are handling certain types of animals. So if you have a lizard, some of these lizards, for example, have weird bacteria in their saliva and you get bitten by them. We're not going to cover all these things. Like I said, there's probably 100 bacterial infections that can cause infections of the skin. But a couple we did talk about anthrax. There is inhalation anthrax, which causes a lung infection that's not as common in humans. Humans are more likely to get cutaneous anthrax, which is in the skin. You can see the lesions are black. This is from the toxins, basically killing the skin tissue and causing it to be necrotic. So a bit more common with people that are dealing with animals. Veterinarians and things like that are always on the watch for cutaneous anthrax. A couple others I just want to mention very quickly. We talked about vector-borne diseases in Canada. And the two vector-borne diseases you need to know are Lyme disease and West Nile virus, okay? But it's just worth mentioning that there are a few more, either spread by ticks or mosquitoes. They're just a lot more rare, okay? One that I keep hearing about in the news once in a while is Rocky Mountain spotted fever. Don't get tricked by that, thinking you can only get it in the Rocky Mountains. It's actually found all over the place. In fact, in Canada, I think it's more east of Saskatchewan, if I remember correctly. It's been very hard to find a nice map of Canada with this, but this is another tick-borne disease. A lot more common in the States, and you can see that it's all over, not just Rocky Mountains. So, like I said, just keep in mind, there are other vector-borne diseases that you may see in your travels. You can see the numbers here. I looked this up the other day, average of 0, 1, or 2 cases a year in Alberta. So not usually a big deal, but it does pop up once in a while. Another disease you may have heard of, I don't want to spend a lot of time on it, is something that's commonly called flesh-eating disease or necrotizing fasciitis. And this is caused by Streptococcus and Staphylococcus generally. And comes up once in a while. This is where you're getting a deep infection of the skin, and it's causing all this necrosis of the tissues. And pretty rare, but it does happen once in a while. And of course, it's just horrifying to talk about the whole thing. So sometimes you end up seeing it in the press or in novels and things like that a little bit. But not going to get into any details of this. Like I said, there's lots of skin infections out there. I just thrown this one up because I found this cute picture. If you like cute cat pictures, there's one for you. There's cat scratch disease. I think there's a song. Is there a song? Cat scratch fever. I'm trying to think if that's Motley Crue or one of those old bands. Like I said, many types of skin infections. This one will actually get into the lymph nodes and cause some inflammation there and some swelling and whatnot. I won't have this one on the final exam for sure, 100%. But like I said, just to show you, there are many different types of bacterial skin infections. The big ones are, of course, Staphylococcus Pseudomonas, Streptococcus. We're going to see those ones again and again and again when we go through all the body systems. Okay, this is just one of the tables from the textbook. So one thing to look at when you flip through the textbook, right? Take a look at these tables and you'll see that, it's kind of summarizing some of the information that I'm giving you, maybe sometimes in a different way. Sometimes it'll have other organisms in there. Like I said, didn't really want to get into talk about acne a whole bunch. We've kind of, wanted to cover sort of the more crucial ones. And you can see they're kind of breaking down the different kinds of infections, right, in terms of the skin and soft tissues, which means it's getting a little bit deeper, sometimes more serious. Obviously, it becomes super serious if it gets from the skin and gets into the blood. And then we're talking about a lot more serious condition. Okay, so we also talked about some viral skin infections. Okay, so we can start off by talking about the herpes virus family of viruses. Herpes simplex 1 and herpes simplex 2, of course, are responsible for cold sores and genital herpes. So generally, herpes simplex 1 is causing cold sores, and generally herpes simplex 2 is causing genital herpes, but both are capable of infecting both tissues. In some ways, they're kind of similar. It's softer tissue, and there's other things that make them biologically a little bit more similar. It is possible to get herpes simplex infections of other body parts. Ocular herpes is a rare thing that happens once in a while where people, and often it's the case with people with cold sores. You can imagine you're touching your face and you're rubbing your eyes, and sometimes people get an ocular herpes infection. And there's again, it's a lifelong infection like all herpes. You can't clear it. You can only treat the symptoms. And for some people, it can, if it's not looked at, it can lead to vision loss, which is unfortunate. The other skin infections caused by herpes viruses are the varicella zoster virus, which causes chickenpox and shingles. So chickenpox classically was a childhood disease, and it actually hides out in the nerve ganglia. So that's where the virus lives, and it hides. And so typically kind of the general progression is later on in life when somebody's immune system is weakened, maybe they were sick from something else, the virus can reemerge, it comes out of its latency, and it's in the nerve ganglia and can cause a rash known as shingles. And in some cases, it's actually quite painful. The people, are bedridden and they can't move because it's just too much pain to move around. Generally now, people who are old enough to have had chickenpox as a child are getting a shingles shot later on in life, and I think it's around 55 or something like that. I'm not sure what the recommendation is now. It used to be like 65, and then they kept dropping it, and I think there's just been enough people that have had shingles younger and younger. I know 2 people had shingles in their 30s, right? So you think you're super healthy then. And you get another infection and your immune system just kind of gets beaten down and you can get shingles. So anyway, yeah, we'll see in the years to come with the chickenpox vaccine what's going to happen with that. Maybe this will be something that will disappear after a few decades because people will not be getting chickenpox so much anymore as a child. We'll see. So let's talk a little bit about measles. Okay. I've mentioned measles a few times as an important disease, something that has been very close to being eradicated in Canada by vaccination. So it's not worth kind of talking about it a ton, but it is something making a comeback just due to people not getting their children vaccinated and whatnot. And so it's worth touching a little bit on measles because it's actually pretty serious. Compared to chickenpox, I think like in chickenpox, it's something like 1 in 5 or 10,000 lead to serious disease and complications and death. I think it's 1 in 10,000 death, 1 in maybe 2,000 complications. So it's not that common, right? Most people are getting chickenpox and it's blisters and you're talking about maybe a scar somewhere, right? I think I have a chickenpox scar like right here. Right, and I think I mentioned before, my son has one that's sort of just in his eyebrows. So there's a little patch where he's not growing any hair. So that's the worst part, right? And some people obviously get much more work, and we don't want scars on our faces. But measles, on the other hand, in terms of the number of hospitalizations and whatnot, it's much, much larger. You may remember there was that Ebola epidemic that happened in the Democratic of Congo. I'm not sure what year that was, 4 years ago now. And it was the biggest Ebola epidemic that we've ever had. And I think it was something like 14,000 people died from it. And it's kind of scary. It's still in other countries. And, in fact, there were even a couple of cases that made it across the ocean to the United States. I think the UK and Spain ended up with a case. So this was Ebola, right? And everyone's, of course, freaked out over Ebola, which is, probably a good thing. But if you actually look at the numbers, I think 40,000 children died of measles in the Congo during that epidemic just due to lack of vaccinations. I'm not sure if it's Congo or if it's all the 3 countries, but more children died of measles than Ebola. So very serious disease. A lot of people got a rash, very bad rash. You're talking about, kind of the typical viral symptoms that people have. So things like a fever and fatigue, that's the immune system trying to fight the whole thing. Sometimes runny nose and whatnot. And it actually can get secreted by respiratory, by aerosols. And I'll talk about that in a second here. Here's some numbers here, right? About 1 in 4 get hospitalized, and about 2 in 1,000 die from measles. These numbers change a little bit just based on geography and other places. The death rate is higher in developing countries where nutrition and things like that and healthcare is not quite as good. But these are numbers for what were the cases in Canada in the 1960s before the measles virus, before the vaccine was widespread. So what else can we say about measles? Measles may be the most infectious thing we know of. Numbers vary, but usually the number I'm seeing is about 1 to 18. So that means that for every person who's infected with measles, they will infect 18 other people, assuming that there's no vaccination or immunity in the population. This is an aerosol disease. That means that someone with the measles can breathe it out and walk away, and it will float around in this room for 2 to 3 hours. So this is why when there's measles outbreaks in schools, there's one case of measles, the school goes through everyone and says, who's not vaccinated, you can't come here until we get this figured out, right? And because, like I said, very, very serious. So this is something, like I said, we're seeing a bit of a resurgence of it because of questions around vaccinations and things like that. I do have some numbers here for a minute. I think I had mentioned some of these things already. Why are people dying? Complications in the lungs, things like pneumonia and whatnot, and sometimes encephalitis. Encephalitis is, of course, affecting the brain. And this was something else I mentioned as well, is that measles actually affects the immune system. It will kill memory cells. So it's kind of like an immune system reboot, right? Where suddenly people's immune system is having issues remembering things that we'd had before, and this can be very serious. And this is something actually we're learning a lot more about recently. This whole thing about immune cells, we had known it affected the immune system for many years, but this was only learned in the last 5 years in terms of what exactly it's doing to our immune system, which is very fascinating stuff. I had some numbers here, some charts, and you can see number of measles cases in Canada. If you look at these charts, what is that, 50, 60,000 measles cases per year. This was also something that was kind of a rite of passage, kind of like chicken pox. Everyone got it when you're a child, kind of thing. It was super infectious. It was just a matter of time. Usually when you start going to school and you're exposed to other children that may also have measles. Vaccine introduced 1963, which is kind of halfway or sort of a third of the way up here. And you can see the number of cases basically plateauing until about 0. And so this is some recent data. In the year 1998, measles was basically gone in Canada. And then since then, there's a few cases every year. Like I said, 98 is kind of an important year for in terms of what's going on with people and questioning vaccines and whatnot. But you can see here's the number of cases here up until about 2019. It's relatively minimal. which is good. Some years are worse than others. I can't remember what year there was a massive outbreak in Quebec where I think like 100 people got measles or something like that. I can't remember what year that was, a few years ago now, but there usually are a few cases every year. 113, 2019. I couldn't find really good data for 2020 or 2021. Question?
What happened in like 1998? Why people decided to no longer get vaccinated?
Was when Andrew Wakefield published that whole thing about autism and stuff. Yeah, and that was the year that was published, and then there was, I mean, it's 20 something years later, and we're still dealing with the ramifications of basically some bad science.
Did he come up with a paper again saying that his study was false?
He didn't.
Okay.
The co-authors in the paper basically said, yeah, it's been retracted, and the co-authors had all basically said, yeah, this was some bad work. I mean, it's interesting, something kind of interesting to get into if you look at what he was doing. He was actually funded by an anti-vaccine group, which is one issue. I think there were 13 kids in there, which is scientifically, like, that's not really statistically very good. And they actually already had autism before they got the shot, some of them, and like there were a lot of sketchy things about it. It's kind of the big question I have is how it even got published in the first place. But
Genetic disorder.
There is genetic aspects, and it has partly to do with your immune system, and there's a lot that we don't understand in terms of the onset of autism, right? And so there's a lot of kind of correlations, right? Children who get autism start to get it, maybe 6 months to a year, they seem kind of normal, and then suddenly they have this onset of, their behavior starts to change. And of course, that's the time around 6 months to a year when they're starting to get their, childhood vaccinations. And so, the human brain, we like to see patterns, right? And sometimes when you see things like that, your brain is like, is this a coincidence or not, right? And then of course you have a very vocal scientist, and of course the advent of the internet and social media and things like that, and it's kind of was a perfect storm of events, really, of the whole thing. It's kind of an interesting thing to follow. It's not the only time that people have been questioned about vaccines. Of course, this has been going on since the beginning. We're sticking stuff in our arm. Nobody wants a shot, right? And questioning those kind of things, right? But anyway, don't want to digress too much more. I do want to move on. Okay, but thanks for the question. So one thing to know about measles is it's also called rubeola. So don't get that mixed up with rubella. Okay, rubella is also known as German measles. And if you take a look here, the measles virus is a negative strand RNA virus, and the rubella virus is a positive strand RNA virus. So they're actually different viruses, and they give rashes all over the body, and the rashes actually do have some differences apparently in terms of the tone and things like that. I can't really say I've seen these rashes, but just photographs, and usually the rubella, in my mind, at least from what I've seen from the pictures, is it's a little bit more intense looking in terms of the colors and whatnot. Both of these things have a couple of things in common, though, besides the fact that they are causing rashes. Both of them are relatively infectious, measles a lot more so. But both are very dangerous to pregnant women. And so when, I think I'd mentioned before, when the vaccines came out in the 1960s, it was great. This was something that people were concerned about back then when they were pregnant, getting exposed to some of measles or rubella, because these viruses can actually go through the placenta and affect the fetus, and leading to stillborn or I believe growth defects, unfortunately. And both are in the MMVR vaccine. So the MMVR vaccine stands for mumps, measles, rubella, varicella. Okay, and that's part of that inoculation. Okay, so almost done. Skin infections. A few others to remind you of things that we talked about. We did talk about yeast infections, which is sort of the skin, I guess. It's kind of on the surface of the body, I guess. So the two kind of classical ones we talked about were thrush and vaginitis, vaginal yeast infections. And so generally, this is not something that's spread from person to person. This is generally, you're getting it from your normal flora. We can find candida in the mouth, the skin, the vagina. It's found in small quantities on most everybody, and it's just looking for a chance to basically thrive. And so sometimes the chances that your immune system is just not developed, like in babies, or maybe your immune system is disabled, like in AIDS, or in the case of vaginitis, it often has to do with just an imbalance of the normal flora are changed. And sometimes that means that a person has had another illness and they've taken antibiotics, and now the yeast has a chance to thrive because the bacteria are dead, and you know, it can form those hyphae and cause the inflammation. Usually not too serious, more about itchiness and discharges and things like that. We also talked about other fungal skin infections, of which there are many species, and usually they're not characterized by the species because there's many of them. Usually they're just characterized by the body part. So this one here, for example, athlete's foot. The scientific name is tinea, which means a skin fungal infection, and then pedis, which means foot. And there's a whole bunch here, and usually I don't even remember the names, the scientific names, because they often have a lot of other names to them that just are referring to the body part, like athlete's foot or jock itch and things like that. Generally with these kind of things, like I said, we're not diagnosing which fungus because antifungals for skin infections usually work quite well. And so it's not usually that important to actually figure out which fungus it is for skin infections. Just a reminder that some of these fungal skin infections are called ringworm. So ringworm because it leaves a ring-like rash. This is very different from the bullseye rash you would see on someone with Lyme disease, by the way. You can see this woman here, for example, all these little rings around in the neck and chest area, and not caused by a worm. I'm not sure why it was called ringworm, but that's just kind of the common vernacular for it. Thought I had another slide here on this. So how are these things spread? These can be spread by, you can get fungal infections from the environment. Of course, there's fungi that live everywhere in the soil, on trees, on animals and plants, and things like that. They can be spread from person to person, which happens relatively common apparently with athlete's foot. Sometimes people, you know, they're at the gym and they forgot their towel and they borrow a towel, right? Those kind of things happen all the time. And these fungi, they love moisture. So things like athlete's foot are a little bit more common in the spring when there's a lot more moisture in the air, and so easier for people to get, of course. Prevention, you know, hygiene, kind of the typical stuff, you know, keep dry and clean, and that's kind of one of the big things, and try not to share stuff if you can avoid it anyway. Treatment, whole bunch of antifungals out there. And we talked about the azoles, for example. There's also Lamisil, which is a different type of compound, and they come in creams and sprays, and you know, usually they're applied topically for these kind of things. All right, lastly, we've got the bigger organisms causing skin infections. So we talked about lice. Remember, there were 3 kinds of lice. We had head lice, and they like to latch onto head hair. There's also pubic lice, and pubic hair and head hair, of course, is a different kind of hair. And so they prefer latching onto you know, one hair type over the other. Pubic lice, in some rare cases, actually can latch onto eyebrows, apparently, or and eyelashes. I don't know. Imagine the hair. There must be some similarities between pubic hair and that kind of hair. Kind of horrifying to think about it. And there's body lice. Body lice isn't necessarily latching onto hair. It's usually latching onto clothing. And so, you know, again, that's a hygiene thing, a little bit more common with people, homeless people, for example. There are some diseases that can be spread by lice, not usually in Canada. I think trench fever is an example of one of those. There's another one. I'm trying to think of what it's called. It's believed Alexander the Great died of it. I can't remember what it's called now. Scabies is another type of multicellular parasite. Scabies is not an insect. It's a mite. How many legs does a mite have? 8. Yeah, so it's not an insect. Insects have 6, mites have 8. They're more closely related to spiders. And you might be familiar with mites that infect your animals. If you have a dog or cat, sometimes they get different types of mites as well. Burrows under the skin, also found in the soil, and we can get treatment for that. And then the last one on there is the duck schistosomes. Okay, and if you remember, what these ones are doing is they're infecting waterfowl, which is animals that like ducks. So, you know, we've got ducks, geese, loons, cormorants. There's probably a few in there. I'm not thinking of swans. Those are waterfowl, right? So it's the bird and then a snail. So it's a bird-snail thing that's going on. And once in a while, we happen to go swimming in a place where, well, these animals are found everywhere. And, you know, the little parasite is swimming along and it burrows into our skin thinking this is a duck. And then the parasite will actually die because it can't live in the human host, but then it can cause itchiness and in some cases severe allergic reactions, which of course is not good. Usually goes away after a few days though, or sooner if you're luckier. Okay, so let's move on. We're going to get into respiratory infections. I'm just going to check to see if there are any questions in the chat box. Not yet, anyway. Okay. So respiratory infections. So respiratory system, starting up at the top, right? We can talk about sinus and ears, and as part of the respiratory system, and all the way through to the lower parts of the respiratory system, including the lungs. A lot of these places have natural flora already, which can cause these infections. As you get deeper into the lungs, it's usually most people are calling the lungs sterile. It turns out that's not completely the case, but it's kind of true, right? In terms of just the number of organisms are barely detectable in a normal healthy individual. Obviously, you get an infection, something like pneumonia, it's not really sterile anymore, but generally that's the case. And that's partly because we've got that mucociliary system that is all those cilia and the mucus trapping things and basically bringing things out on a regular basis. Potential pathogens, there's a whole bunch. This is actually potential pathogens here for the upper area, so sinuses and ears and those kind of things. You can see Staphylococcus, Streptococcus, Candida. Haemophilus, you're going to see that one on a bunch of lists. It's actually called Haemophilus pneumonia, and it actually is not the main cause of pneumonia, but it's one of those organisms that can affect a lot of things as well. It just didn't really cover in this class. So some terms for you. We got pharyngitis, which is inflammation of the throat, okay, and pneumonia, which is inflammation of the lungs. So just to distinguish between those two kind of things. So I think I've got a little bit on pharyngitis, which sometimes is called strep throat if the cause is streptococcus, right? Okay, I guess I said this already. This is protected very well by the mucociliary system, which is all the mucus getting pushed up and out. So let's talk about strep throat for a minute or two. Strep throat, sometimes called streptococcal pharyngitis. Everyone I know calls it strep throat. Usually the typical symptoms are super sore throat. You can barely swallow, if anything. And sometimes if you look carefully, you can see spots. I thought this was a pretty good picture showing the spots. And so, you know, if you know somebody who you're suspecting they have strep throat, you can look for those spots back there. There is a rapid test that's been out for a while now. And a lot of pharmacies are offering that now. So rather than going in for a clinical appointment, you can go to a pharmacy. I think there's a charge like $15 or something, but saves you a bit of time. And the only thing to know about the rapid test, I'm not sure what it's at now, but a few years ago, it was only 90% accurate. And I know this because I actually had strep throat a while ago, and I was sure it was strep throat, right? I was just so sure. And I think maybe I mentioned this in class before, and I told the nurse that was doing the rapid test, it's kind of over here on the right side. Of course, she goes in and does the left side, right? And then it comes back negative. And anyway, 90% accurate, that means 1 in 10 people are getting the wrong answer with the test. So then they did the overnight swab. So they took another swab that went in a tube and got cultured, And the next day they phoned me and said, okay, yeah, it is strep throat. We're going to send a prescription to your pharmacy kind of thing. So like I said, usually kind of the big thing is the red spots and the barely being able to swallow. Some people get a fever and other kind of things from there. Sometimes, swollen lymph nodes and whatnot. But kind of the big thing is not being able to swallow. In many cases, this will resolve on itself eventually. But there is the risk, of course, from streptococcal infections that they can get deeper and more severe. So it is recommended that people do get it treated, particularly if they can't eat at all. That's obviously a big deal. So a little bit more about streptococcus. The one that causes strep throat is usually Streptococcus pyogenes. I see there's a question. I'll grab that in a second. So this is the one that we're calling group A strep. There are other group A strep organisms, but this is kind of the main one. And this is the one that can cause all sorts of other infections. Of one I mentioned already, which is the flesh-eating disease. And you're going to see Streptococcus pyogenes. It's going to kind of come up again and again and again in all these lists. But maybe most famous is for strep throat. So if you remember, this is a gram-positive, it's a catalase, a negative organism, and it is the one that is beta hemolytic on the blood agar. Here's a list of some of the things it can cause, right? So strep throat is on the list, impetigo is on the list, so some things we talked about in flesh-eating disease, something called scarlet fever, toxic shock syndrome, and this list can go on and on. Again, it's an organism that is well adapted to infecting multiple body systems. Okay. So somebody just mentioning he or she had strep like 3 times and came back negative each time. I don't know whether they were doing the rapid test or whether they were doing the overnight test. I think, with the rapid tests, it's easy to rely on them nowadays. And so sometimes they're not necessarily doing the overnight test anymore. But like I said, 10 years ago, I know they were only 90% accurate. That may have improved by now, but often that's the case, right? And in many cases, it is resolving on people's own, or they elect to give you the antibiotic anyway. Particularly if there's the red spots, sometimes it's kind of like, okay, what else is that going to be? They're kind of distinctive if you've seen that enough times. So a couple other things about Streptococcus. Something kind of going back to topic 12 is it has all sorts of virulence factors that makes it extra pathogenic. And I saw this little diagram from the textbook, and you can see it's listing a whole bunch of them. One is that it has a capsule, and this capsule is it's a carbohydrate on the outside, and it is making it hard for the immune system to really get a good grip on this thing. And in fact, there's been a lot of animal studies that show if you mutate and knock out this capsule, they're barely pathogenic at all. Some other things on there, you can see it's talking about some toxins. One of the toxins is recognized by your immune system, your hypothalamus, is going to cause fever. And you may recognize the mention of this M protein, which was in that immune video that we were talking about. And this is what often you get an immune response against, because it's found on the surface of these organisms. There's others out there, like hemolysins. This is what is breaking the red blood cells, and so on. So this is just showing that it has a lot of adaptations that are allowing this thing to get a foothold in multiple body systems. So what else is there out there? Diphtheria, barely worth mentioning because it is basically eradicated due to, in Canada, due to vaccination. But it's worth mentioning because this vaccine is one of those, a good example of a toxoid vaccine. Remember, a toxoid vaccine is the vaccine is basically an inactivated toxin. Diphtheria, the toxin is apparently very potent. One toxin is enough to kill an entire cell. And it somehow, I'm not entirely sure how it works, but I believe it interacts with ribosomes and basically disables them entirely. And so the cell can't do anything with its ribosomes. The cell is basically dead. And there's somebody there with diphtheria. So it kind of depends on where it gets into the system, but I don't actually know a lot about diphtheria. Many infections are named after the part of the body they're causing issues. So there's sinusitis, which is, of course, infection of the sinuses. This can be caused by many viruses, can be caused by many bacteria. And again, I'm not listing everything, just kind of the usual suspects. So you can see there we've got streptococcus and staphylococcus yet again. Otitis is the ear, and streptococcus, another streptococcus, pneumonia. So streptococcus pyogenes and streptococcus pneumonia are the two that are important. And you can see, like I said, they are very capable of infecting many body systems. There's also pertussis, which is also known as whooping cough, and that is specifically infection by one organism, this one here called Bordella pertussis. So that one we have a vaccine against, and there's actually a couple of different vaccines. One of them is acellular, one is cellular, and I'd have to look at the formulations to see what the difference is. So pertussis is one of those ones that is preventable by childhood vaccination, but this is one of these cases where the vaccine isn't quite as good as some of the others. I think this vaccine is something like 75% effective. So there's always a few cases every year. I think like 100 cases every year in Alberta. Probably a few more that aren't diagnosed. You know, people get sick, they stay home with a cough. A lot of people aren't getting diagnosed from this. The illness tends to be a lot less severe if you are vaccinated. I know someone who actually had it a few years ago, and I actually asked her, "Oh, did you have the vaccine?" She said, "Yeah," but I mean, she's like, I don't know how old she is. Don't want to presume. I think she's over 50. So probably meant last time she had her shot was when she was like 6 years old or something, right? So again, sometimes immunity does wane, particularly giving a few decades. All right, let's talk about pneumonia. Okay, pneumonia is very serious, and one of the top 10 killers worldwide is pneumonia. Pneumonia is basically an inflammation of the lungs, and there are many causes of pneumonia. As long as you have something in the lungs causing inflammation, pneumonia could be caused by something that's not pathogenic. People could be inhaling some sort of, let's say, dust particles or sawdust or something could cause pneumonia in theory, right? Number one cause is bacterial usually, and so we'll talk about that in a second. And like I said, a really big killer worldwide is pneumonia. Most common cause, Streptococcus pneumonia. Other bacterial causes, you can see there's a list here, and then it's kind of a bunch of the usual suspects, right? We've got Staphylococcus, we've got Klebsiella, Pseudomonas, E. coli in some cases, Haemophilus influenza. Haemophilus influenza was named, and then we found out that it wasn't the cause of influenza, but the name is stuck. So go figure. It's just one of those things, those quirks of biology there. So Streptococcus, number one cause, and I think I have a stat here somewhere. I think it's like 60 or 70% of the cases are caused by Streptococcus. Yeah, there it is, 60%, right? So the good news is that this is usually treatable by antibiotics. I had pneumonia, just trying to think that was, now, and I remember they prescribed me penicillin V, which would cost $4.25. That's how much the prescription was. And my drug plan, I didn't have to pay the cost of the drug, but I had to pay the dispensing fee, which was $16. So I thought that was ironic that the drug was much cheaper than the dispensing fee. There are vaccines available now. And I'm actually having a hard time keeping track of these vaccines. I believe this one here, PCV13, is now given to as a childhood vaccine. I'd have to look that up to double check because that's kind of a newer thing. There's also this other one, Pneumovax 23. I actually had Pneumovax 19 years ago. So the numbers just basically list how many carbohydrates are in that vaccine. These are subunit vaccines. They don't have any pathogens in them. They just have carbohydrates that are found in the capsule of the bacterium. And so I guess I got shortchanged. I only got Pneumovax 19. But like I said, the formulations on these seem to be changing every time I look them up. Every few years, there's something new with them, and so I'm not as familiar with them as I'd like to be. So, not just bacteria causing pneumonia, there's also many viruses that can cause pneumonia, and this turns out to be more common in young children. There's a lot of these infections that children either don't have immunity or they have weak immunity to, such as influenza, para-influenza. There's a whole bunch of adenoviruses, some things we haven't talked about. This one here, respiratory syncytial virus. There's another one I was reading about in the news that is really virulent, but there's only like a couple dozen cases a year in the United States and 1 or 2 in Canada. I can't even remember the name of it, but it causes really severe pneumonia in children. These are viruses, so usually the treatment is treat the symptoms, right? Bed rest and those kind of things. Penicillin will not help, and this is part of the diagnosis. Physician trying to figure out whether the person has viral pneumonia or bacterial pneumonia, and sometimes that's the case with the treatment, right? Trying to decide whether to give treatment or not. Sometimes the treatment does include, giving small immune suppressants, right? Steroids and corticosteroids and things like that that will kind of, bring down the inflammation. And if they think it's bacterial, they'll of course prescribe antibiotics. All right. Okay, where are we? I think we're doing this on here. So let's talk a little bit about tuberculosis. We have talked about tuberculosis here or there. I'm just going to check, see if there's any questions. Let's see what we have here. Looks like we're good for now. So let's talk about tuberculosis. Tuberculosis, we've talked about it here and there, once in a while. And in Canada, was hugely important historical disease. People were getting it in much, much larger numbers and very, very serious. And there was a time when tuberculosis, people would get the disease and there were no antibiotics. And so if you watch enough movies, sometimes there's these sanatoriums, where people were hanging out for months to either live or die from tuberculosis was the whole idea. Some people do recover from it and some people don't ever recover from it. I keep seeing these stats about tuberculosis, and there's a lot of questions about the numbers of cases that are found worldwide annually, because it's probably one of the #1 diseases that is not reported in many developing countries. And some places I'm seeing numbers, and I think this is a very high estimate, but one place I saw estimated that 2 billion people worldwide are infected by it. I think that's probably high, but let's cut that in 4 and let's say 500 million people. There's a lot of people that have it and don't know they have it. And that's what we're going to talk about a little bit here. Number of cases in Canada has plummeted in the last 50 years, which is great. And we do have treatments for it as well. So this was an acid-fast organism. It has a mycobacterial cell wall, which means it has that mycolic acid in it, which makes it extra resistant to staining by the Gram stain. And it also tends to be resistant to kind of most of your traditional normal antibiotics. So penicillins and erythromycin, none of those things work very well on tuberculosis at all. I don't know what that's all about. Maybe a little note I was going to say. So where is tuberculosis relevant in Canada? Anybody could get it, but there's kind of 2 populations that are maybe the highest risk in Canada. One is Indigenous people who live in Canada's north. Although that would include Indigenous people in many parts of remote parts of Canada, including Fort McMurray. Particularly in Nunavut a few years ago, there was actually quite a bit of tuberculosis going on. This is an advertisement campaign, and they're handing out brochures and making them available to people. And part of the problem is that so when you get tuberculosis, you kind of get a chronic cough, and how many of us had a cough and you just don't do anything about it? Well, sometimes people don't do anything about it for months, right? And of course, that's giving the potential to spread it. And when you're living in a remote community, you may not have the best access to healthcare. And when you do, sometimes you end up with healthcare practitioners who've never seen tuberculosis before. So you've got all these problems compounding themselves. And so they spend a bit more time raising awareness and training people to recognize it, and we're able to bring the number of cases down quite a bit. The other population besides Indigenous people living in remote communities is actually homeless people as well. Again, people who aren't maybe less likely to get access to regular health care and probably have a number of other health issues, and kind of persistent chronic cough may not be the number one thing on their mind in terms of priorities to deal with, unfortunately. Okay, what is going on here? Let's try it. There we go. Okay, so what's going on with tuberculosis? It's a respiratory disease. I just mentioned spread usually by a cough, so respiratory droplets. There is some data to suggest it can be airborne, and we'll talk about transmission a little bit more in a minute. But it gets into the lungs, and what happens in the lungs is the immune system can recognize that this is a foreign invader, and these macrophages, these are cells that can envelop things by phagocytosis. But the thing about Mycobacterium tuberculosis is it can survive phagocytosis, right? It has that waxy layer, that mycolic acid, and that is protective enough that this thing will survive. So that's actually what you're seeing in this image here, is you're seeing the organism surviving inside the macrophage. So the organism can survive, and what happens is sometimes these things start to lump together, and they form these things that are called tubercules. And these can sometimes rupture and actually be visible on an X-ray. And so this is where the name tuberculosis comes from, right here. And when they rupture, of course, you're looking at bacteria that have multiplied and they're escaping, and you're looking at inflammation of the chest, which leads to coughing and probably more transmission in many cases. So there they are escaping, and like I said, these are visible sometimes on X-rays. I think I have an X-ray photograph here in a minute here. And there's a little cartoon showing the lungs and the abnormalities that they're seeing in the lung tissue. So let's just talk a little bit about progression of tuberculosis, because this is kind of the interesting thing about it, which makes it kind of a scary disease where, like I said, it could be 500 million, could be 2 billion people actually having this. A large percentage of people get infected by it, and there's no disease that happens, right? Apparently, it's actually quite hard to get tuberculosis. If you're exposed to somebody with tuberculosis for like one day, apparently that's not enough. Usually it's somebody you're living with or you're exposed to again and again and again that you're going to get tuberculosis from. Not going to say that's always the rule, but apparently that's the case. Usually you have to have multiple exposures and long-term exposure to actually get tuberculosis. So a certain percentage of people actually get infected. It's 10 to 30% what I can find from numbers. And, like I said, depends on your exact exposure and those kind of things. So then the other thing is that maybe 90% of those people who get infected are not going to get progression to disease, at least right away necessarily. So they're going to get latent tuberculosis. So latent tuberculosis, it means that the organism is in there, it's hiding probably in some macrophages, and the immune system is just kind of keeping it at bay, right? And it could be at bay for a long time, it could be years, and maybe someday it will progress to active tuberculosis. So about 10% of those cases. You can see it says here it's a slow progressing disease. It grows very slowly, and sometimes it takes a couple of years before people actually get relatively serious symptoms. And then you can see it says here some people develop disease later. So untreated, it's going to take a while, but apparently death happens in about 5 years. Some people remain chronically sick for much, much longer, and some people recover. So you can see this note here about developing due to immune suppression. And I had mentioned before that if you are somewhere in an African country and you have tuberculosis, often they will test you for HIV the very next thing, because they're suspecting that you have some immune suppression, because it's possible you fall into this category, you have latent tuberculosis. So how do we detect tuberculosis? The classical method is that acid-fast stain that we talked about. People are starting to use more immunofluorescence now to detect the organism. And it turns out that there's actually a whole bunch of different types of tests that are used that are a lot more accurate nowadays. There's a PCR test, so that's similar to what would be done with the COVID test, right? It's a nucleic acid type of detection test. And there's a newer test I was just reading about that they're doing now, which is standard, and it's basically a kind of ELISA test. So they're looking for something, a marker in your blood that you have that is part of that response against tuberculosis. Another thing that probably I think you guys have to get skin test as part of this program. Yeah, so you're probably familiar with that skin test. This is one of these delayed immune responses. So they scratch your skin a little bit with one of the antigens, and then is it 24 or 48 hours? 48 hours they're looking for that. And every once in a while I meet a nursing student that either found out they had latent tuberculosis or they find out that they had a vaccine against it, right? This happened to my mother. Late in life, my mother became a crossing guard for a school, right? Part-time job. And the school board is like, okay, you do your tuberculosis skin test. And she tested positive, and they figured that she was old enough that she actually had the vaccine as a child. And so, of course, if you had the vaccine, you're going to test positive. There's another student here about 5 years ago. I think that was the case. Is she thinks she had the vaccine when she was a child in, I think it was India. She wasn't really sure, but they did the other tests and they couldn't find any suggestion that she had the organism, except for the skin test came positive. And then I have met a couple of students that found out they had latent tuberculosis and had to go through the treatment. There are trained animals. This is interesting, worth a Google. Look up rats trained to detect tuberculosis. I don't know what they're doing. They can smell something. But it's cheaper than all of these other things, right? So there are people that are using these to detect tuberculosis in countries where it's cheaper to have a trained rat than it is to do all these other things, right? I see a comment there, question. Tuberculin test, yeah. Yeah, that's what it's called. This is something that evolves all the time in terms of the tests and the treatments. I want to talk a little bit about comparing latent and active tuberculosis. Symptoms, latent, there's not usually any symptoms. It's being kept at bay, no coughing, nothing like that. Doesn't feel sick. Active tuberculosis, the big ones are the chest things, coughing and pain in the chest. Those are kind of the big ones. Obviously, it can get more severe. Sometimes people are coughing up blood. Sometimes fever, fatigue, weight loss. They used to call tuberculosis consumption. I don't know if anyone's ever heard that. I was watching some movie on there. There's this movie with Nicole Kidman, and I think the big reveal in the movie, sorry if you haven't seen it, is she's a ghost. You know the one? Anyway, it comes out that she died of consumption, right? And so sometimes you hear that in these older movies where they're talking about consumption, and that's because of the weight loss. People just have no appetite, right? When they're sick. Transmission. If you have latent tuberculosis, as far as we know, it's not being transmitted. Okay, they're not coughing, so they're probably not transmitting, and it's kind of just hiding and kept intracellularly. Active tuberculosis, usually it's respiratory droplets. I think I mentioned before, there is some evidence to suggest that tuberculosis can be transmitted airborne. That means the pathogen is in the air and can linger for a few hours. I was reading about one study that had done, I think they literally had some guinea pigs in one room, and they had a hole up in the, like through the ventilation, and had some guinea pigs in another room, and they were able to show that it could be transmitted in that manner. So that's kind of interesting, because usually bacterial diseases, bacteria are kind of big, right? They're usually gravity is a bigger deal for them, but I guess it has been shown experimentally anyway. There is, yeah. Just a second here. So somebody's asking if it can be transmitted through saliva. In theory, yes, but usually it's more inhalation, right? Because respiratory droplets, which would, be from saliva. Another question was if there still is a vaccine. Yes. My understanding is it's not a very good vaccine in terms of the effectiveness, 45% or something like that. And my other understanding is that often there's a lot of people have adverse reactions to it. One of the big reasons it's actually not used in Canada is because people just don't get tuberculosis anymore. And it's actually very useful to have that skin test, right? So it's an antigen, I don't remember which antigen in there, but yeah, it's basically a bit of antigen, and they're just looking for that reaction under the skin from your immune cells. Yeah. But my understanding is, yeah, that the vaccine is not as good as they'd like it to be. And there are people actively working on trying to prove that, because there are parts of the world where this is hugely important. Madagascar, for some reason, tends to have a lot of multi-drug resistant tuberculosis. So if the drugs are useless, we got to do something else, right? And but most of us, it's not going to be an issue probably in our lifetime. Good question. So diagnosis, many methods of diagnosing. The skin test is often the first thing that people get and they realize they have it. Problem with the skin test is that if you have latent tuberculosis, it doesn't always work. It's like 80% in the skin test, but at least we have the skin test. Like I said, there's other methods. There's this quantiferon ELISA, which is kind of a technical kind of ELISA, which is looking at I can't remember which immune molecule they're looking for in the ELISA. Classically, what used to happen is if you came up with a positive skin test, which happened to my mother, they sent her to the hospital for an X-ray. Now we have these blood tests, these ELISA tests. So I think that's usually the second thing they do is send people for the ELISA test to take a look at that. Classically, it used to be the sputum test where they would be looking at under a microscope. That's not so good. It's not as accurate in terms of you got to have really well-trained technicians. It's laborious. The ELISA tests are a lot better. So treatment, this is where it gets complicated. And this is the kind of thing that when I look it up, it changes every once in a while. If somebody has latent tuberculosis, sometimes it's one drug. So that one we talked about, isoniazid. Sometimes there's one or two other protocols out there. Generally, you're looking at least 6 months of treatment for tuberculosis. Very slow growing, very hard to treat. Sometimes with the latent tuberculosis, what they will do is the person will get one drug for 1 month, and then 2 months of this one, and then back to drug A. And so there's a few regimes like that. People who have active tuberculosis, they're more likely to get some sort of multi-drug therapy. And the big concern is any multi-drug resistant tuberculosis. And that happens every once in a while. I remember when I was in high school, some new guy shows up, moves in out of town, and literally on like week 2, he vanished for 6 months. So, everyone's like, what happened to the new guy, right? And it turns out he had multi-drug resistant tuberculosis. So they were quarantining him and having a hard time treating it as well. I see there's a question. Let's see what that is. Yeah, so somebody's just saying pre-ingestion, which is possible, yeah. So this is the kind of thing, like I said, that changes all the time, and particularly when they're looking at what kind of tuberculosis is floating around in that particular community. The multi-drug resistant stuff is what people are really scared about because we don't have a lot of tuberculosis drugs. And, maybe 8 to 10 antibiotics are effective. And so what do you do when you run out of that list? It's going to be tough to treat. And Madagascar, for some reason, has tons of multi-drug resistant tuberculosis every year. Okay, so move on to viruses, and probably this will finish off today, and which is good because I was kind of hoping to finish the respiratory infections. There's a whole bunch of viral respiratory infections, and I kind of want to just talk about these 3 for a few minutes, okay? Because they're similar, but they're different, right? So we've got the common cold, COVID-19, the new one on the block, and influenza. 3 important respiratory infections. I do have a fourth one on the list, which is not a respiratory infection. I want to talk about the stomach flu, which really bothers me when people call it the stomach flu, because flu means influenza, which is a respiratory virus, but it's a common vernacular, which means it's here to stay. People are not going to stop causing gut infections, the flu, for some reason, but I do like to correct people, so that's why I have it up here. So let's take a look. What are the causes of these things? We're talking about different viruses. The common cold, big one is rhinovirus, which is like probably 70% of common cold is caused by rhinoviruses, which is a bunch out there. But there's also coronaviruses. There's 4 coronaviruses that cause the cold. There's adenoviruses. There's parainfluenza. There's there's a big list. These are kind of the main 3, right? These rhinoviruses kind of being the big one that cause the cold. COVID-19, of course, is caused by SARS virus, SARS-CoV-2, and that's the one that everyone's talking about. Influenza is usually caused by influenza A or B. There is a C. I don't think C usually causes human disease, and of which there's many, many strains of that. New one floating around every year. Gastrointestinal infections, something entirely different. And often when we say stomach flu, we're talking about norovirus. We're going to talk about norovirus just a little bit more next time. But I'm throwing it on here because, like I said, people call it the stomach flu or the flu, and it's not the flu. Okay, it's norovirus, something totally different. Do these things have vaccines? I may have not updated the notes I put online. I think I put not yet for COVID-19 or something like that, which may have been the issue, which was the case last year. Now we have 4 vaccines in Canada that are approved for COVID-19. The common cold, no vaccines. The flu, we have an annual vaccine, and the annual vaccine nowadays is quadrivalent, which means it's protecting against 4 different strains of flu. I don't know when that switched. It used to be trivalent, 3 strains, and now it's 4, maybe 8 years ago or something like that. Norovirus, no vaccine. So you can see already we're looking at some differences. Different viruses, different profile in terms of our protective measures. And if you take a look at the profile of symptoms, there's a lot of overlap, but there's also some things we can say about these things, right? So if you take a look at the cold versus COVID-19 and influenza, right? If you have a cold, rarely looking at a fever. Sometimes a headache, sometimes aches and pains, like sometimes all these things. COVID-19, pretty common. Flu, really common to have a fever for these things. Influenza, very common to have aches and pains and headaches as well. What about a cough? Again, cold, some people always get a cough with a cold. The majority of people, it's sort of more sometimes kind of thing. With a cold, you're usually looking at a sore throat, runny nose, more symptoms. Shortness of breath, more common with COVID-19 than the other ones, all right? So you can see kind of, like I said, a little bit of different profile of these diseases. Loss of appetite, this is not usually, sometimes children do get some gastrointestinal infections from these respiratory viruses. Not so common in adults, right? So it's more of a sometimes kind of thing. Whereas if you take a look at the stomach flu, it's rarely, never, very sometimes, but when you get to the vomiting, diarrhea part, because it's a gastrointestinal infection, now you're talking about getting some symptoms there. And what was the last one? Possible complications. This is the big one. A cold, not usually. Sometimes people get other infections. Sometimes a cold might turn into pneumonia, but that's a secondary infection or an ear infection or something like that. COVID-19, this is the crazy thing about this, is the possible complications. Who knew that the list was going to be so long? We're talking about blood clots, heart inflammation. It turns out this is not just a respiratory disease, but it actually is infecting the vascular system, which is leading all sorts of weird things out there. This COVID toe, I don't know if you guys have seen that one, where people are getting weird rashes on their feet. And of course, the more serious complications are things like pneumonia and death, of course, right? Influenza, can pretty commonly lead to pneumonia and sometimes other complications as well. And in many cases, people who die of influenza are often dying of that secondary infection, which is 9 times out of 10 is pneumonia. Norovirus, the worst complication is getting dehydrated, right? You can actually die from dehydration. In some cases, people are having, losing a lot of liquid from the diarrhea.
An article on COVID, and they said hypoglycemia is one of the
I know.
diabetes.
Every time I look up the symptoms, like that list is so long, right? And particularly, and of course they're talking about people that have other, other conditions. And it seems like, you have this and then you got this and this to worry about now too, right? It's kind of crazy, but I think it's just reflecting the fact that it's not just infecting the respiratory system, but that it can infect other body systems, so the vascular system as well, which in many of these diseases is obviously it's a crucial part of the body, right? Yeah. Of course it does.
And so now they're finding like random people are just diabetics now.
Yeah, I haven't heard that one, but I wouldn't be surprised, right? I know diabetics were one of the list of people that need to be really concerned about the disease, and that was known very early on. So that makes sense if it is infecting the pancreas. Yeah. Yeah, this is crazy stuff. Let's talk a little bit about COVID-19. I know we've been talking about here and there all semester. I just wanted to say a few things about it. So remember what it stands for, right? That was one of the questions on the first midterm that too many people got wrong. I did not like that. And here's the funny thing, right? We had your midterm, and then I told my other class that, I said, a lot of people got that one wrong. You guys should probably know that one too. And then I put as the bonus question on my other midterm, and only half of them got it right. So, sometimes hints are worth listening to. So this is a new virus, right? Probably originated in bats, and seems to be infecting more than just the respiratory system, which is the kind of thing that is causing issues in some people. Thankfully, most people get mild disease, but unfortunately, it's been causing us a lot of grief. And it's going to take years for us to get back to whatever normal was anyway. This is the kind of the big list of main symptoms, right? Fever, shortness of breath. 1/3 of people lose smell and taste. So I had COVID-19 a year and a bit ago in September, and that was one of the symptoms I had. I have this tea at home that I bought, and it's just awful. It tastes awful. But I drink it when I'm sick because there's sort of this psychology that, bad things that taste for you is good when you're sick. You know what I mean? Like I just have this thing, okay, this is my sick tea. I'll drink it when I'm sick only. And I took a sip and it just tasted like hot water. And I'm like, what? Yeah. And so like, not everything. I could taste some things. Like I remember having a sandwich with mustard on it. It tastes mustard, but not the tea. So that lasted for about 4 days for me. But I know a friend who had it, and he had no taste for like, he said 4 to 6 months. And apparently in some people it could be permanent. I don't know if that's the case. I've just heard that as a rumor. They're finding that they can treat people with antihistamines on this in terms of that there seems to be some success there. So a lot of respiratory symptoms, a lot of typical symptoms of what you get when you get a virus, fever, things like that, and then some vascular symptoms if it's getting in deeper. So transmission seems to be primarily through respiratory droplets, but it can be transmitted airborne and through fomites. And this is why everywhere you go, we're just talking about staying 2 meters apart, because just statistically, if you are close to somebody and kind of more than 10 to 15 minutes, that is increasing your odds of getting exposed to those respiratory droplets a lot more. Not sure if anyone's doing this anymore. Still seeing the signs, but wherever you go, everyone is just tired and is doing what they're doing, right? Yeah, it is what it is. Incubation period. This is the thing that makes this disease nuts, is because the incubation period is 1 to 14 days, and many people have no symptoms, and they're transmitting and have no idea they're doing so. Prevention. So we have 4 approved vaccines in Canada. Obviously, the hygiene and all that is going to help. Treatment in Canada, we have 1 approved treatment, which is remdesivir. That's by IV, so that's kind of a last resort kind of thing. We have these monoclonal antibody treatments. I believe there's 2 or 3 that have been approved in Canada for treatment. Again, it's sort of when people are quite sick, you're looking at intravenous treatment, and then we're looking at mostly treating the symptoms, of course. There are a whole bunch of other ones kind of in the pipeline that may get approved someday. But in terms of full approval, this is what we're looking at. Okay, so not enough time to talk about influenza today, unfortunately. Next day, I'll probably have to make some decisions about some things to cut out because I do want to talk about the exam next day. So I'll focus on what I think is some of the essential stuff. And but do take a look at the PowerPoints. Like I said, I may be skipping a few slides next day to make sure that we can cover all the material that I feel we really need to touch on. Other than that, thanks for coming. I will see you on Thursday.